Yeah, let's do that.
There we go. All right. Hello, everyone. I'm so happy to be able to give this talk today. It's definitely a really important topic for us to really start to pay more attention to. I think that, in the history of medicine, women have been a population within, medicine that has been neglected in one way or another. And we're really learning that all of these differences do matter, and we have to, start addressing the differences and paying attention and trying to kind of use those differences to help with care and support women. Okay, I think that that's different. That's definitely one of our aims today, is to help everyone understand a little bit what's going on. And so today with our lecture, what we're going to do is we're going to really dig down into the clinical differences, the things that we can see in Parkinson's in women that might be a little bit different from what we see in men. We'll also talk about some risk factors that are specific for women. We'll talk about therapy differences, considerations that we should take into account when we're thinking about what treatment options we have and how to use that treatment to our advantage. And then we'll also be talking about the biological mechanisms underlying these differences, unmet needs of women, and some of the current scope of the research related to women and Parkinson's disease. So I'll start with gender differences in Parkinson's disease. We know that in general, PD affects men twice more often than women. However, we also know that sometimes the differences of Parkinson's in women can sometimes cause a little bit more of a challenge, or even more morbidity. Even in women, the symptoms can be more distinct, and the differences in the therapies compared to men are also different. And so we sometimes arrive at challenges a little bit early on compared to men. Women are also less likely to have a specialist, just a regular neurologist, not even a movement disorder neurologist in their care team. And so that also lends itself to some differences in care and treatment. Women also show distinctive prodromal markers compared to men in their presentation or their evolution of the Parkinson's. So we tend to see some symptoms start a little bit earlier on, or there is a difference in some of these prodromal symptoms in women compared to men. Go to the next. Some of the risk factors that we tend to think about with Parkinson's are related to what we think of Parkinson's as being a multifactorial disease, meaning that it's really an interplay of multiple factors coming in to cause the disease. So we think of there is likely a genetic component, and there's also many environmental factors that also play in with those genes to eventually cause the disease. In terms of genetic factors, we know that there are mutations that seem to have equal effects on men and women. So if you have this particular mutation, it means that your Parkinson's is probably going to be the same, or the risk of getting Parkinson's is the same in a man and in a woman. All right. So genetics kind of is a bit of a more of a level field. However, there are other aspects of Parkinson's or other risk factors that women aren't in this level field. And so one of them being anemia. We know that iron and the metabolism of iron in the brain can sometimes be different in Parkinson's, or we can see differences in iron in the brains of people with Parkinson's, and anemia seems to be one of those risk factors. And we know that women in general tend to have anemia more often. This is mostly related to the fact that women go through menstrual cycles and are losing a lot of blood every month, and so women in general just tend to have anemia more frequently than men. And this might be a little bit of a risk factor difference. Women also have some protective factors compared to men, and some of these tend to be more related to occupational hazards and some of the trends that we've seen in occupation and exposure to chemicals and insecticides and things like that based on differences in occupational choices within women and men. Women tend to also have lower rates of head trauma compared to men, and that's a positive, right? So that's good. We don't want head traumas. Head trauma can definitely be a bad risk factor for developing Parkinson's. And then, like I said, some of the occupational exposures, even some of like the military exposures and things like that, have been more prevalent in men than in women. So that's always something to think about. But, as the time change and women are more and more equal in the workforce, I would say that that's probably something that might equalize a little bit. And we'll have to see how that changes over time based on how women enter the workforce and kind of do more and more of these other jobs that might be having some of these exposures as well. And then the last bit is estrogen, right? It's the one hormone that we think about with women that might actually have also a positive effect in the risk of developing Parkinson's, meaning that more estrogen might be related to as a protective hormone in the process of developing Parkinson's. But also, going through menopause and all the hormonal changes that women go through, this also might be a time or might be a factor that some women might be at increased or lower risk depending on their hormonal status. So we'll also talk about some of the differences in what Parkinson's looks like, right? So Parkinson's, when we think of Parkinson's, we think of the tremors, the stiffness, the changes in gait. And so this also can sometimes look a little bit different in how it emerges in someone with Parkinson's that's a woman. So typically we see symptoms start to emerge a little bit later in women than in men. We also see less of that stiffness and rigidity and more of the tremor as the presenting symptom, as a symptom that women come in with or that notice first. There also tends to be a little bit of higher propensity for gait instability earlier on in disease. And this is something that we really need to pay attention to and focus on and kind of put a little bit more emphasis on, because we know that gait instability and falls is a major part of disability and morbidity and mortality, right? And so as women, we really need to focus on making sure that gait is doing well, that we're doing everything that we can to prevent the adverse events or adverse effects of potential gait instability. So that's one that we really need to, keep aware of and try to maintain as much as possible. And then the last bit of the motor symptoms that tends to be different in women is the response to some of the medications that we give, but namely levodopa, which is our gold standard go-to medications for the treatment of, all of the motor symptoms of Parkinson's. And we know that women in general have a higher risk for developing some of the complications related to this medicine. And so it's something that we'll talk a little bit more when we get to the treatment part, but it's definitely something for us to keep in mind and be aware of and careful when we're deciding what treatments we want and when to start them and how much to engage in those kinds of treatments. I tend to think about the motor symptoms as kind of like the tip of the iceberg, and then we have the whole iceberg under the water, and that tends to be all of the non-motor symptoms that come along with Parkinson's. And really, the non-motor symptoms can really substantially affect our quality of life. And at the end of the day, what we really want is to maintain quality of life and functionality. And so taking a look at the non-motor symptoms is really important, and knowing where we stand in those non-motor symptoms. In women in general, we tend to see fatigue be a big part of that non-motor component, depression, anxiety. Restless legs can be a little bit more common. Pain is a big one that we tend to see often in women. We can also see weight changes, usually in the negative, right? Losing weight being a concerning risk for disability, gait instability, and things like that. and as well as other autonomic symptoms like excessive sweating and constipation. Sometimes less common in women, we tend to see less of a cognitive impairment, and we tend to see less of some of the other autonomic symptoms like um, uh, urinary or sometimes blood pressure changes. And REM sleep behavior disorder tends to be a little bit less or a little bit less active in women than in men. Some of the unique challenges that women face, and I think that we'll try to emphasize a little bit today, are that are very unique to women. One being hormones, right? Estrogen and menopause, and how it affects Parkinson's symptoms and in all stages of women, right? Hormone and how do we approach it when it comes to hormone replacement and its impact on treatment with Parkinson's, right? Another thing that is very unique to women is how the disease progresses and how treatment in that disease progression should be considered slightly different than with men. We know, like I said, that levodopa and the response to levodopa can be different. And so we really need to kind of keep that in mind and know that it can be unique for women. And then lastly, surgical interventions like deep brain stimulation, actually, we see lots of differences in terms of DBS. We know that women in general tend to go for DBS a lot less, but what they don't know is that women tend to do way better or much better in terms of quality of life and improvement of their symptoms after DBS. And so there seems to be a little bit of a disconnect in terms of getting those treatments and understanding that we can really, make quality of life a lot better for women. And so that's one of the things that we'll discuss today too. So I wanted to go to the considerations of treatment in Parkinson's in women. As I mentioned before, levodopa is really our gold standard treatment for Parkinson's, and studies have shown that women, when they take levodopa, a lot more of that levodopa is bioavailable to them, meaning that they are able to use a lot more of that levodopa compared to men. And so they don't need as high of doses as men do to get the same benefit. Women also, like for that same reason, they require lower doses. And that also plays into the fact that women are more likely to develop drug-related dyskinesias than men. Those drug-related dyskinesias tend to be those wiggly, dance-like movements that can happen when the dose of the levodopa is a little bit high. And we tend to see women encounter these dyskinesias at lower doses of levodopa and sometimes earlier on in disease compared to men. Ways to kind of combat that is to really communicate with your doctor about those concerns, and also keeping in mind where you are in terms of doses, right? Are we overdosed? Are we underdosed? And knowing that we maybe don't need as higher doses compared to men. The other part of this is once we get to the later stages of Parkinson's, where we tend to see a lot of the motor complications related to responses in medicine. So we tend to see the medicine with not last as long. So we have off periods in between doses, and we see the dyskinesias come on most of the day and things like that. At that point is when we decide to go for DBS. And we know that the women that undergo deep brain stimulation end up having higher quality of life measures compared to men, particularly in mobility, stamina, and cognition. Women do really well in those particular domains after DBS. Women, however, are less likely to get this treatment. They make up less than 25% of the population that are even referred to DBS. And that doesn't even count the people that are referred and then say, no, I don't want to get this DBS. And so it's really a small amount of women that even go through the process. This also probably relates to the fact that less women are seeing neurologists, less women are seeing movement disorder neurologists, and so access to care is probably playing into all of this. But there's a lot of factors that go into why we're not, seeing more DBS in women. Um, and so it's an interesting interplay in some of the social dynamics, and the fact that women are underserved in Parkinson's and in the scope of neurology and movement disorders. So we can go on to the next one. We really need to kind of find ways to make it better. There's also lots of psychosocial and quality of life considerations in women that we need to take into account. Coping with the social stigma and the emotional toll of Parkinson's. We know that when women are diagnosed with Parkinson's, their perceptions of their own womanhood can change. How they view their own bodies, their perception of what others think of them can become very negative. And this is sometimes related to the impact of the physical symptoms that Parkinson's can sometimes have. For instance, right, the kind of like the masked face or the inability to show as much emotion in the face can really affect someone and feel like they're not being themselves, right? And those limitations of the limitations that those symptoms have or place can also affect their ability to take care of themselves or take care of others, since women also tend to be or tend to fall in caregiver kind of roles within their families or within their circles. Spousal relationships can change, and it sometimes can definitely affect women and how they perceive their role in a relationship or within the family. And that's something that can feel really isolating for women. And these are some of very unique considerations that women kind of go through. We also know that in general, women tend to feel like who they are within their relationship with their family and their friends, and take on those like those caregiver that I care for you, and I'm gonna be that role can change, and having someone else step in that caregiver role for them can be really difficult, and those interpersonal relationships can sometimes suffer. But at the same time, we can definitely provide support, right? And provide recognition that there's a lot out there that we can do to kind of make either those tensions kind of less, or learn ways to reduce some of those negative thoughts that can really affect quality of life. Go to the next. Let's see. There we go. So as I mentioned, caregiving and family roles are really unique to women. It's a unique burden of caregiving that is often, assumed by women in our society. And these challenges for women balancing both their personal care and then the care of others around them can really cause some difficulties with their quality of life. It's the demands of caregiving tend to affect women specifically. We tend to see, for example, married women with disabilities receive fewer hours of informal caregiving compared to married men of the same level, at the same level of limitations. So that tends to happen, and women who are ill are more likely to need non-spousal help to fill in those gaps. This tends to happen, and we see it in the research that it shows that women with Parkinson's are twice as likely to have a paid caregiver compared to a man or men. in that trend, we also see that women with Parkinson's tend to have less of a psychosocial support, and tend to have less caregiving resources. And so one of the goals today is for us to really kind of dig through that and find ways to give more support and find those caregiving resources. And I think next slide. What we really need is more research as well. We know that there's lots of gaps in our knowledge of both the differences of Parkinson's in women, but we also know that there's a lot of gaps in how we treat women. And so we really need some high quality research to be done that tends to be prospective, looking forward, longitudinal studies analyzing these differences. And then with that information, we can also do more research that translate into a more tailor-made management of Parkinson's for women. This can include hormone therapy. This can include, other medications or things like that that are more tailor-made for women and their personal challenges.
So Dr. Steep has talked about kind of the differences in symptoms and presentation for women versus men. Now, why is there a difference? Why is there such a difference in Parkinson's between the two sexes? We don't know that much yet why that is. Studies suggest that the dopamine-producing neurons, the ones that are affected in Parkinson's, may be less vulnerable to neurodegeneration or to toxicity in women compared to men. That might be why men are more likely to get Parkinson's than women. There's also been some studies showing that there's a difference in the types of markers that change with Parkinson's. In men, the markers related to inflammation and oxidative stress, which is kind of like accelerated aging of brain cells. So markers related to that are increased, suggesting that these processes might be more common in men. Whereas in women, markers of mitochondrial dysfunction, so mitochondria is kind of like the powerhouse of the cell. Abnormalities in mitochondria and protein clearance, since we also know that there's protein buildup in Parkinson's disease. So some studies suggest that markers in these areas are more increased in women compared to men. Differences in hormones, not just estrogen and testosterone, but also growth hormone levels and luteinizing hormone, which is another reproductive hormone. These levels are different in women compared to men. Studies also suggest that the Y chromosome in males has certain elements on that chromosome that may make men more susceptible to Parkinson's disease and linked to progression. We've talked a little bit about estrogen, progesterone, maybe being neuroprotective in women, but also that beneficial effect may be subject to changes based on the different life stages of women that we'll talk about. Whereas testosterone may actually worsen neurodegeneration. So again, this is still very rudimentary. We don't know too much about this yet as to why there are differences, but certainly a need for more research in this area. Now, the interest in the difference between the sexes, we see studies back in 1990 that start reporting differences in progression and mortality of Parkinson's disease in males versus females, but still not a whole lot was discovered or analyzed. In 2010, there was another paper calling for more research and improved clinical studies to look at this issue. And there was a little bit more after that, but still, in 2022, a really nice paper came out by Dr. Subramaniam and many female investigators, several of them who actually have Parkinson's disease. And they talked about the unmet needs of women living with PD and the gaps and controversies. Again, indicating that there's still a lot that needs to be done in this area and a lot that we don't know yet. One of the main gaps is redefining the image of Parkinson's disease. when Parkinson's was first described, the first illustration of Parkinson's disease in 1886 was of a man, an elderly man, stooped over. And unfortunately, even if right now you do a Google search, you'll still see this image come up as Parkinson's disease, an older man, and usually an older white male, bent over. But we know that that's not all that Parkinson's disease is. There's so many faces of Parkinson's disease, and showing women as having Parkinson's disease is still lacking, and people still think of it as a disease of the elderly men. But having more of this in literature, just out there for the community to raise awareness that this is a common disease in women as well as the different stages of Parkinson's, not just the advanced hunched over one, but also the mild and intermediate types of Parkinson's and how it can look different in on time versus off time. The other gap, we talked a little bit about risk factors, but there's still a lot that we need to learn about how risk factors are different in women, because this may help us understand why some women get it and others don't, and that of course leads to how we can prevent Parkinson's in the first place. So in men, caffeine and smoking have actually been linked to a reduced risk of Parkinson's disease, and pesticide exposure has been linked to increased risk of Parkinson's. But that has not been clearly found in women, so they don't seem to have that same risk association. In terms of the occupational background, there was a study of over 90,000 women, an observational study that followed over 90,000 women, 3,000 of whom developed Parkinson's disease. And they found an evidence of excess risk for occupations in health technology, social work, teaching, counseling, and building and ground cleaning and maintenance in women in terms of what may increase risk of Parkinson's disease. We talked a little bit about the genetics as well, and more studies are trying to find the differences in men and women, what genetic predispositions increase risk in women compared to men. So for example, the alpha-synuclein gene, which is that protein that builds up in Parkinson's disease, that's actually leads to a higher predisposition in men. Whereas the LRRK2 variations are more common in women. And then there's several others that have shown some differences and may affect how disease progresses differently and presents differently in women versus men. And then lastly, bone density, lower bone density and osteoporosis have been shown to lead to increased risk of Parkinson's in postmenopausal women. We'll spend a little bit more talking about hormones, because that often tends to be an area of interest. And one of the other gaps that exist is, how do the different life stages of women affect their PD journey? We know that of the 4 stages, the menses, the pregnancy, perimenopause, postmenopause, they can all affect how the Parkinson's is affecting them. The symptoms, for example, is right around premenstrual stages, people can have worsening in their PD symptoms temporarily. We still need to improve our understanding of how does contraception affect Parkinson's, impact of relationships, career, family planning in young onset PD women. Pregnancy, the areas that we need to understand are preconception counseling, maternal safety, the effects of medications on the baby, on the fetus, guidance around childbirth and breastfeeding safety. Perimenopause can also lead to worsening in PD symptoms, and women have to make the decision of sometimes surgical menopause versus natural menopause. This is around the time in hormone replacement therapy. The question of that may come into effect. Postmenopause, again, we're thinking about the hormone replacement therapy. There's also the issues of breast cancer, osteopenia, osteoporosis, pelvic floor dysfunction, also a transition in social roles, going from working or being a mother to grandparent or retirement or loss of a loved one. The other interesting thing, I think, is that, we know that menopause starts around 60 to 65 years of age. And interestingly, the perimenopause starts at around 45 to 55 years of age. We also know that PD starts at this around the age of in the postmenopause stage, but people can have prodromal symptoms decades before the Parkinson's diagnosis, and that's around this stage, probably around the perimenopause stage. So people, things may be happening at the hormone level right around the perimenopause stage before you even hit menopause. And, does that have a link to increasing the women's risk of developing Parkinson's disease? Which leads us to, what is the role of estrogen in Parkinson's disease? We talked about why we think estrogen may be neuroprotective. There is an increased risk of PD in men, suggesting does estrogen make women less vulnerable to get Parkinson's disease? We also know that compared to women without Parkinson's disease, women with Parkinson's disease have been shown to have higher testosterone levels and lower estrogen levels circulating in the blood. We also know that there's a higher risk of occurrence in Parkinson's disease in postmenopausal women compared to premenopausal. The duration of fertile life, a greater duration of fertile life, is associated with delayed onset of Parkinson's disease in some studies, but not all studies. In animal studies, estrogen has been shown to have protective benefits, including decreasing inflammation and preserving the dopamine-producing brain cells. So there is less loss of the brain cells. But applying this clinically, what do we do about hormone replacement therapy in women? Is it recommended? Is it not recommended? And unfortunately, the data is still conflicting and controversial. We don't have an answer to that. Some studies show that hormone replacement therapy may reduce risk of Parkinson's disease, while others show that it may have no effect or increased risk of Parkinson's disease. And I think the reason behind the conflicting data is because there's so many variables in hormone replacement therapy. There's the question of getting just estrogen versus a combination of estrogen, progesterone. There's the type of estrogen, there's two different types on the market, esterified and conjugated, which is basically kind of how estrogen is made. One is synthetic, the other comes from, I think, cow urine or something. So the type of estrogen you get. Then there's the way of administration. Some people get oral, some people get pads, some people get injection, or there's also creams. And then the type of menopause, surgical versus natural. So a hysterectomy or something like that versus just, natural menopause. So the data that we have are from people who've been followed and they just received whatever was given to them rather than controlled clinical trials. So sometimes that's why we don't understand, what may be the best way to give it. There's also the window of opportunity in terms of timing of when hormone replacement therapy is given. Is it better to give it midlife or early when it may have a more protective benefit? Because that may be that prodromal phase of Parkinson's, right when things are starting to change in the brain, but you don't have symptoms yet. Or do you want to catch it early at that point? So is there a certain window opportunity for when the hormone replacement should be given? So I think these are still things that we need more research on. We probably need more controlled clinical trials on to try to come to an answer on, when to give hormone replacement in women with Parkinson's. The other gap, we touched on this a little bit, is understanding factors that affect quality of life in women. We talked about how women may have less social support, more psychological distress, and worse self-reported disability and quality of life at initial PD care visits compared to men. Women tend to have more caregiving responsibilities along with, sometimes they're still working or they have other competing demands. with the diagnosis of PD, women's perceptions of their own womanhood can change, and they can become very negative towards themselves. Women may also prioritize symptoms that affect their ability to organize and strengthen social relationships and become distressed when they're unable to do this. So especially as providers too, I think it's something for us to be aware of when they're talking about their symptoms, asking them more about how it's affecting these abilities of being a caregiver or being somebody with caregiving responsibilities or being active in their social relationships, and trying to tailor our treatment to make sure we're improving their symptoms to the extent that they could keep on doing those roles. There's also gaps in terms of delays in diagnosis, misdiagnosis, and cure experience in women. Women will often have a delay in getting diagnosis or referral to specialists. Women and underserved minorities may have even more of a delay or also be more likely to have a misdiagnosis. We know even less in women in sexual and gender minority groups like LGBTQ community. So this is an area that we really don't have much information on in terms of the women's experience. Women with PD can also feel like they're not being heard by their providers or other caregivers in their family. So it's important, for us to listen to women when they're talking about their symptoms, and that is a way to strengthen the provider and patient relationship. And they might not consistently share their concerns and symptoms with their providers, especially around more sensitive topics like mental health issues or pelvic floor problems. So it is also important for us to, again, build a more relationship of confidence so that they can feel better about sharing these symptoms and us even asking about these symptoms. In terms of what can be done about this, so we need to find ways to improve access to care for women, as well as educate them more about the advanced therapies like DBS, or make it possible for them to consider it. Customize the treatment based on their own personal symptoms, their body weight, and unique metabolism, which may be very different than men. Ask about the sensitive topics, be more willing to refer them to specialists, or having a lower threshold to refer them to specialists. Provide them with guidance on self-care, stress reduction, and social connection strategies that may be particularly more beneficial to women than men. Educating male caregivers so they can understand the disease better and have resources to provide support, so that they have that support when they go back to their family. And then developing more models of support for women in the community. So outside of their family, finding ways to help them connect with others in the community. Other things that we need to work on is increasing awareness of the hormonal stages in women living with PD. I think if women have more awareness about it, they'll be more likely to bring it up with their neurologist. There also needs to be a better collaboration between neurologists and gynecologists. I admit to this that we don't often talk, the neurologist with the gynecologist, but I think it is definitely something that needs to be done, especially as we understand more about the role of hormone therapy and when to start somebody on therapy, so that together, both of us, both specialties can discuss the risk benefit and specifically for the specific patient and their unique story. We need to develop tools that empower women to bring up women's health issues with providers. So I'll talk about one of these tools in a minute, but, some ways that women can feel comfortable bringing this up with their providers, and develop strategies to help women when they're going through exacerbations in their PD symptoms around the time of their menstrual cycles or menopause or pregnancy, finding ways to having strategies to deal with those. So how to raise awareness for women with PD? Parkinson's Foundation did this really interesting project, this really important project, I would say, over a course of 2 years, called Women in PD Talk. So what they did over the 2 years is that they had regional forums across the country, as well as a national forum. And it was really to, bring women together to understand the experiences of women with PD. And then out of this came a really nice agenda, which I think Monique and the group will share with you. This is the first national research and care agenda specific to women with PD. And it really addresses the priorities identified by women and the disparities experienced by women. And it's called Closing the Gender Gap in Research and Care. And it's really listed out kind of what we should focus on over the next decade. And I think people have started to work on some of these areas. There are other groups like the Women's Parkinson's Projects and PD Avengers, specifically a women's working group in PD Avengers that's really trying to, again, raise awareness, elevate the voices of women with PD, engage more women in PD and as well as in research and give hope for women with PD. And I think they're great groups to follow if you don't know of them already in terms of the work they're doing. Some of the research has focused on tracking experiences of women with PD, PD Generation, for example, which is also part of Parkinson's Foundation. And again, something I think that came out after those forums was to develop a women-specific questionnaire to address women-specific experiences in their PD clinical history. So PD Generation, I don't know if you know about this or not, it's a genetic study that's been done nationally where they're collecting samples from men and women to try to understand the genetics behind Parkinson's. And using this questionnaire, that now they're trying to link the women experiences to the genetics to try to understand if there's associations. Fox Insight, which is an online clinical study by the Michael J. Fox Foundation, now has 2 questionnaires specifically for women. And Fox Insight enrolls like thousands, tens thousands, people with Parkinson's, as well as healthy people to try to, again, collect data over time. And they're trying to understand experiences of women living with PD, their health and home life, as well as questions around peri, and postmenopause. Somebody with Parkinson's disease created this interesting app called My Moves Matter. It's a digital app, I think that's available now to everyone, which allows people to track their PD symptom fluctuations across menstrual cycle. Also for, people postmenopause, because it allows them to track things alongside their hormone replacements or other women health issues. So I think again, when I was talking about giving women tools so that they can bring up these issues with their providers, this is one such tool where they can keep track of it and then take it to their neurologist and discuss, oh, these are the symptoms I experienced when I was going through premenstrual symptoms, or any other variations or women health issues. So I think there need to be more things like this that will allow us to understand their experiences women go through. One of the questionnaires actually by Fox Insight and PD Avengers actually created the questionnaire and then distributed on Fox Insight, and it led to this report about self-image in women with Parkinson's disease. And again, they surveyed over 2,000 women, and 61% of women reported that PD negatively impacts their self-image. And after motor symptoms were the things that affected their self-image the most, the tremor, the rigidity, the dyskinesia, gait changes, slowness, facial masking. But right after the motor symptoms, the 2 non-motor symptoms that affected their self-image the most were urinary issues and speech changes. So I think it's good for us to know which symptoms are, affect them the most, so that we can focus on these in clinic and try to find better treatments for these symptoms. Other things about, research that's being done. The PPMI study by the Michael J. Fox Foundation is a huge landmark study, as you may know, that's looking at biomarkers in Parkinson's disease, and it's enrolled over 2,000 participants and following them over time, looking at their clinical symptoms, patient-reported outcomes, imaging markers, biological symptoms, to try to understand, again, what predicts who gets Parkinson's disease and how Parkinson's disease progresses. And even though it's a study of men and women, I think the interesting thing to note is that even though there's twice as more men that have Parkinson's disease, the study is really trying to enroll, equal amounts of men and women, 54% men, 45% women, to really try to understand the differences. And I think, a lot of their analysis is looking at the differences in men versus women and their Parkinson's disease. But some of the priorities for future research, first and foremost, is to get women included in research, right? Getting more women into research studies so that we have information about them and we analyze data from research studies, from drug trials, from exercise trials, any sort of trial, so we understand how women respond to different treatments, including women across diversities, demographics, stage and onset of Parkinson's disease. Areas specifically for women, I think that we need to focus on are, again, the unique needs of women. We need to include topics that examine the effect of biological sex and sex hormones on PD risk, progression, and response to treatments. Studies need to dissect differences between PD, aging, and menopause. Like, what is making the symptoms worse in women? Is it the Parkinson's? Is it the aging? Or is it hormone related like menopause? And lastly, the studies need to include not just effects on biomarkers in women, but also quality of life in women, because that is probably one of their biggest symptoms, like we talked about. So anything you look at, whether it's a drug treatment or an observational study, we need to focus on quality of life in women. I just wanted to end by, listing out some studies that we have going on at UCSF. While these are not specific to women, I don't think there's that many research studies that are only enrolling women, but a lot of these studies are enrolling both men and women, and will look at the differences between the two when they analyze the data. So we talked about PD generation, which is a genetic study, PPMI, which is looking at progression of Parkinson's disease. We have a trial starting here about psilocybin therapy for depression and Parkinson's disease. And we have 2 exercise trials for early and moderate stages of Parkinson's disease that, again, want to enroll more women because we want to understand the effects on women. And then TOPAZ, which is a fracture prevention study. Again, we've talked about how osteopenia and osteoporosis is especially an issue in postmenopausal women. And the study is going to look at the effect, the differences in men and women when they get this treatment. The study is giving one of the osteoporosis medications, zoledronic acid, and they'll want to look at the analysis in terms of how men and women responded differently to the drug. So with that, we'll open it up to questions and answers. I think we've gone a little over 45 minutes. So.
Thank you so much. That was wonderful. You such a lovely overview of the differences between men and women and Parkinson's and progression and treatment and all aspects. I think some of the questions I had teed up, you already answered. And one of them was about, what can women do to participate? And you gave a wonderful outline. And so just for the audience, after the presentation, we will email the link to the recording, and I will pull the links to some of these trials and include them so that people can more easily find them. And I did drop in the chat the Women's Research Care Agenda, the one that you referred to, the PD Talks story, where they did sort of 10 regional forums, and then they brought people together and they compiled this really great research agenda. So the link is available there. I think one of the things that fascinates me the most is the sort of different phases that women go through, menses, perimenopause, and menopause, and how those are all affected. And it seems like there's, evidence to show that estrogen is protective. And my understanding is that the evidence is not so clear on hormone replacement therapy. So I'm wondering, like, if you could design, Dr. Luther, if you could design your dream study to sort of address this one issue, because I think that's at the forefront of a lot of women's minds. I mean, in the news, it's, HRT or not, right? But then if you have Parkinson's, it's even a more loaded question. Should I start hormone replacement therapy or not? And how might this affect my Parkinson's? So I'm curious if you have any more thoughts on that, or if there was a study that you would design, what would you do to look at it?
Yeah, no, I think it's a great question. And I think you have to kind of think of it like we would for any disease modification medication for Parkinson's disease, right? If we're saying that estrogen is protective, then we can think of it kind of like some of the drugs we're studying for Parkinson's disease, whether it's the vaccines or the other molecules, that may slow down or prevent progression of Parkinson's disease. So whenever we think of those drugs, to really understand it initially, we want to look at in people who've just been diagnosed with Parkinson's, right? To catch them early to see if you can make a change. So I think similarly with estrogen, if I had to design a study, I guess I would say, we would first we would look at people who've just been diagnosed, and well, in this case, women who've just been diagnosed and see the effect of a hormone replacement therapy at that stage. And of course, everybody would get the same type, whether it's oral or a patch, probably, and probably one of the drugs, just estrogen, and then follow them, for a couple of years and see and compare it to women who don't get it and see if it makes a difference, kind of like we do with disease modifying drugs. And then if it does seem to have positive results, then you take it to more advanced stages of Parkinson's and kind of apply it to all people, right? And I think the reason is, again, because Parkinson starts even before diagnosis, there've already so many changes that have happened in the brain even before you're diagnosed with Parkinson's. So if you're trying to use something protective, you want to use it for the brain before you've lost too many brain cells. So to just get to a basic question of, is it protective, you probably want to look at it at very early Parkinson's first. And then if it's showing benefit, then you look at it across the stages. But I think, because hormone is a little different than other drugs, because in this case, there's also a deficiency, right? We know that there's hormone deficiency in women, especially post-menopause. So I think there's probably also an interest in looking at more advanced stages, maybe it doesn't change the course of the disease, but maybe it changes the symptom severity or the quality of life. So maybe it's too late to change the course of the disease, but it can still improve the overall PD symptom burden by improving certain things. And so I think there's interest in looking at both early and more advanced Parkinson's disease. But yeah, I think when you're doing trials, you probably want to separate the groups because timing is so critical in Parkinson's. And, the hardest thing about Parkinson's is everyone is so different, right? So the more that you can try to control and then look at the effect of a treatment, then you're more likely to have less controversial results. But I think it's probably something that will need to be explored in all stages, both as an early stage to look at its protective role, but also later to look at whether it has a symptom beneficial role or quality of life role.
Okay, so I have a question about DBS, and why do you think it says you mentioned that women are less likely to get DBS, and yet they actually do better afterwards? And is this a combination of access to care or the old story of the symptoms are not being recognized or listened to the same way? And how can women advocate or be a bigger part of the conversation with that?
I can answer this question. I think that there's probably a lot of different factors coming into why women in general get DBS less. Part of it, I think, is that less women are seeing neurologists, and specifically movement disorder neurologists. To be able to be referred to a DBS, surgeon or anything like that, you need to see a movement neurologist first, right? And that's kind of like the gateway into getting DBS. And so just the fact that we're seeing less women see the specialist in general is the first probably gatekeeper. Following that, I would say that second, there might be, some biases, right, within, providers and how we're asking questions and how we're listening to the symptoms, right? Like I said, women have differences in the way that they present and the way that their Parkinson's presents and progresses. And so, if we're seeing more men in general, maybe we're just not asking the right questions to women, right? And it's something that we need to be more aware of and try to remove some of that bias. And then I think lastly and third, a part of it is, and I think that, I'm not sure how much it's been looked at, but one of the I think things to consider is what DBS means for women and how surgical treatment in general is perceived by women, right? Women tend to do have less risk-taking behaviors and things like that. And surgery is considered risky, right? And so women are sometimes a little bit more risk averse. And so we'll decide to, no, I can live with these symptoms and not take that risk. And I think it is our job to be able to educate a little bit better about the benefits and how DBS in general can really be something that is not considered such a risk to not undertake, right? Part of it also, I've experienced, women who are probably good candidates for DBS and they decide to not undergo because they are caregivers to someone else. So they don't want to take the time off to go through the surgery and then all of the things that involve afterwards, getting it programmed and that burden of, higher, medical treatment or seeing providers. It's just not in their wheelhouse of time and what they can do, because like I said, they don't have that support or that caregiver support inherent to their own life. And so they're like, no, I need to focus on this other person that I'm taking care of before I can decide to undergo this really, big treatment that's going to take a huge time for me to focus on. So I think there's lots of factors that factor in, and everybody's situation is a bit unique and different. But I do think that there are probably some systemic effects that are really the big barriers that we need to find ways to kind of start reducing.
Thank you.
Yeah, and one of those systemic barriers seems to be the very first thing that you mentioned, which is sort of access to specialty care. And so
Right.
I wanted to just kind of go back to that question.
Mhm.
And do you have any more thoughts on that specifically? Why women are less likely to get specialty care or get referral to a neurologist? Are they coming in later because of their symptoms, or
It's possible that they're coming in a little bit later. Their symptom onset is a little bit later too, but I think that there probably needs to be a lot more research looking at those before the neurologist kind of question, right? Are these symptoms being confused for something else in women? Are women just not being listened to in the same ways? Are we not describing the symptoms of Parkinson's enough to be able for it to be recognized? Or is it or is it like a systemic, problem within the health field that when we think of Parkinson's, we think of that old, man, kind of hunched over, and it doesn't equate when we see a woman with Parkinson's, right? And so I think that that's probably one of the systemic barriers that we need to do. And as specialists and whatnot, we can do a lot to educate, all the other specialties that will eventually refer to us, right?
Yeah, I think that that's a really good point about the image, like the slide that you had with the old man hunched over. And I was just thinking about that even in the popular media. You know, when you think of Parkinson's, you think of like Alan Alda, and Michael J. Fox, and Muhammad Ali, and Brian Grant, and Ozzy Osbourne, and
Mhm.
they're all men.
They're all men.
I
Yeah.
mean, I can't think of any women, you know, in the media that have Parkinson's. So that's interesting. I
Yeah.
wonder if that's there's a lot less um, that there's hesitation on the part of some of these women to sort of to show themselves as
Right.
that way. There's a vulnerability,
Mhm.
shame, stigma. I wonder if all those things also
Yeah.
play a role.
Definitely. I think the stigma of Parkinson's is very, is in the way that women perceive it is very unique, right? It's not,
Mhm.
we don't see it, we don't see it out in the media as much either. So, how do you break that?
Yeah.
Yeah.
You mentioned that prodromal symptoms were different in the very beginning of the slides for women. And just as for the audience, prodromal symptoms are those that sort of show up years in advance of an actual diagnosis or actual prominent motor symptoms. For example, I think loss of smell and constipation are common. What are how are those differ between men and women, the prodromal symptoms?
I think that we've seen that the fatigue and some of the mood symptoms tend to be a little bit more prominent in women.
Mhm.
I think you mentioned RBD sometimes can be more common in the dream behavior, which we
Mhm.
think of as a prodromal symptom, might be more common in men
Mhm.
than women.
And,
I
like
thought
some of these
maybe-
prodromal symptoms are kind of vague and they're not really, like very specific, right? Like how do you fatigue? That can be a menopausal symptom, right? That can be an anemia symptom. So they're very vague and sometimes difficult to pinpoint, really.
Well, and I would think if non-motor symptoms tend to be more prominent in women, those also lend themselves to being a little more vague and also overlapping a lot more with menopause and
Mhm.
perimenopause in particular.
Right.
Yeah, and can initially be seen through a different lens than
Mhm.
For sure.
Parkinson's might not be the first thing that you think about with those symptoms.
Exactly.
But what I have a question, sort of a practical question about, talking about connecting your healthcare providers, OBGYN with your neurologist, et cetera. So what what would be a good strategy? You're not used to doing this, you're not used to advocating for yourself, and you want your neurologist to communicate with your OBGYN and sort of have that communication going back and forth. Just suggest it to your doctor, just say, I want you to talk to my OBGYN. Like what's a good functional strategy to get that communication going? Because it's not as easy as it sounds.
No, and I think you'll probably run into barriers on both sides too. But the gynecologist being like, "Wait, why do you want me to talk to the neurologist?" And the neurologist being like, "What? Why do you want me to talk to the gynecologist?" And I think, and that's where just having more awareness, not just for women, but for even people in our field, in our training, having this discussion and the need for this is important. So something needs to be done on the healthcare side for that too. But I think for women too, yeah, I think that if you bring it up, as an important issue, and with both your gynecologist and your neurologist, and especially if your gynecologist is kind of on the fence of whether I should do it or not, the hormone replacement therapy, that might be a good time to connect them with the neurologist, so they can, the neurologist can hopefully shed some insight onto the Parkinson's aspect of it. And I think ultimately it will depend on, that particular patient's risk factors. Is there family history of cancer? Is there any way that the hormone replacement therapy may increase the risk of any cancers? Because you don't want to cause anything negative from the hormone replacement therapy, or their menopausal history. Was it a natural menopause versus surgical menopause, things like that. So I think you have to start somewhere, and I'm not sure I have a good guidance on it, but yeah, us educating the healthcare providers more and the women bringing it up with both neurologists and gynecologists. And I think if somebody asked me, like, would you talk to my gynecologist about it, I probably would reach out to her, or send my note with a recommendation or something to the
Yeah.
gynecologist. So I think it will vary initially depending on the neurologist, but I think as we delve more into this field, hopefully that will become more streamlined.
Yeah, thank you.
Well, I think that we're also very fortunate to have you both, as women neurologists. I think that it's also very helpful for a woman to go see a woman specialist.
Mhm.
And so I think that that's really important. So thank you guys for being there and supporting all of the women in the Bay Area.
Mhm.
There's a couple questions about DBS, so I just wanted to circle back to that. These are more sort of general questions. One person asks, is it possible to age out of DBS? Like, can you become too old for the procedure? And second part of that would be, does DBS help with symptoms like balance, fatigue, speech, and forgetting words?
So very good questions. I would say that for in the age out question is not so specific to age, but more related to medical comorbidities. And some of
Mm.
those medical comorbidities can, get, or, the risk of getting more medical problems as we age is more common, right? And so it's really the medical risk of going through surgery that will stop us from getting DBS later on in disease or later on in age. Not really the age is a number, right? So we've had patients that have undergone DBS that are, in their late 80s or in their 80s, but they were really healthy otherwise, right? And didn't have anything that would make surgery more risky than beneficial. And that's really, at the end of the day, what we kind of weigh out, the benefits versus the risk of going through surgery. The other parts of the question were, what does DBS help with gait, fatigue, and speech?
Balance.
And balance. So DBS can sometimes be helpful with certain aspects of gait, meaning that if gait is affected because you're having a lot of stiffness, slowness, rigidity, or freezing that that is positively responsive to levodopa, all of those symptoms can or potentially respond to DBS, right? But if the problem is that you're losing your balance and balance is the problem, DBS can't really help with balance. If anything, it can make balance worse. And so it's one of those things that we do really take careful evaluation of before going through DBS and really advise either for or against it when making that decision. In regards to speech and verbalizing and remembering words, that's another part of DBS that DBS doesn't typically help with. If anything, it can slow down a little bit of that verbal fluency that we kind of consider that comes along with Parkinson's.
So DBS helps more with motor symptoms, is that right?
It
Typically?
helps more with motor symptoms, exactly. So tremor, stiffness, and slowness.
And I think you said earlier that women experience more non-motor symptoms than men.
So they experience more help with like fatigue and quality of life. So they feel, aside from getting the motor benefits, they get a little bit extra benefit, feeling like they got, they have more energy now, they a little bit less fatigue, and quality of life specifically is improved more in women than in men.
Oh, okay. And one question just came in while we're on DBS still, is that anyone specifically studied referrals to DBS by gender? Has that been studied
Question. I
specifically?
think that there has been some Medicare data that has been looked at, but I don't know the numbers, to be honest.
Mm-hmm.
Monique, maybe I'll let Gary chime in with his question. Is this a good time?
I think I just answered them.
Gary's got his hand up.
Oh, her. It's a she, but I think I just answered them. Okay, but if she wants to chime in, sure.
Gary, can you hear us?
Yes, Todd.
Hi, Gary. Go ahead and ask your question.
Well, I just think that if doctors look at men and women differently as patients, in general with PD, it's very likely that they would look at DBS differently in terms of what they think men and women might get out of it. I don't know. It certainly seems that's the gateway. Like, I've asked my doctor and she just says, you're not eligible. Why? You know, I got rigidity, I got tremor, I got balance problems.
Right.
So I just, yeah. Okay, thanks, Todd.
Okay, thanks, Gary.
I will ask a question about, am I on mute? Yeah, I'm off mute. About, I was really interested when you said that women are at higher risk for levodopa related complications like dyskinesias. And I was wondering if you could speak to that a little bit more and why you think that might be.
Yeah, I think it's related to also the fact that the levodopa seems to be more bioavailable to women. And we know that dyskinesias in general, the risk of getting dyskinesias is usually related to how much levodopa you're having. So how big of a dose you take might make you a little bit higher risk for developing a dyskinesia. And so women, if it's much more bioavailable, meaning that they just get more of that levodopa when they take it, then it could be that, they're just a little bit more susceptible to the effects of levodopa in general, and therefore susceptible to the side effects too.
Got it. And there was a general question about levodopa and dyskinesia. Are you of the belief that if you dial back your levodopa and take less, it'll reduce your dyskinesias?
Mm-hmm.
Okay.
I think women, we also talked about like the weight differences, and if women are lighter, even though levodopa, generally we don't think of dosing it based on weight, but there might be, some effects on women being, sometimes smaller than men, weight-wise, maybe not needing as much levodopa. Also, some of the genetics, risk factors and things I talked about, some of the women are often more affected in terms of the genes that are involved in dopamine metabolism. So there might also be some relationship with how they're metabolizing it, the dopamine in the brain, and that may make them more susceptible to dyskinesia. But definitely, I think something I've seen in clinic more too, that I see more dyskinesia in women.
And once somebody develops dyskinesia, and then you sort of maybe reduce your dose of levodopa, does it reverse the dyskinesia, or is that once you begin having dyskinesia, it doesn't, you can't really reverse it? Do you have any thoughts on that?
So I can answer a little bit. I think that when we think of dyskinesias in the context of Parkinson's disease specifically, we do know it's a direct medication-induced side effect, right? So if you take it and you take it at a high enough dose, you're going to get the dyskinesia, right? And so if you lower that dose enough to get away from that threshold to develop the dyskinesias, you might avoid it, right? But by lowering the dose, you might be underdosing yourself and having a little bit more of those other motor symptoms, right? And so we have to kind of strike that balance between controlling your motor symptoms without causing some of the dyskinesias, or kind of reaching a balance between a little bit of dyskinesias but a good motor control, so that we feel the best that we can, right? I think that the dyskinesias, once you develop them, that is your Parkinson's, right? Your Parkinson's responds to levodopa in that way. And so it's not reversible in that way, that if I give you 200 of levodopa, you're going to get dyskinesias. That's going to be constant. It's really based on the dose, likely.
Thanks.
There's a question about cinnamon and eating, and protein, when or when not to eat, and vitamins. Is there sort of a scheduling of, medication? I know some people are more affected with protein intake and their cinnamon, some people are not as affected. Any advice about that? And also in combination with taking vitamins as well, supplements.
Yeah, I mean, in general, what we tend to advise is avoiding taking cinema at the same time as food, especially with protein, since they have to go enter the body through the same receptors. So generally eating, taking the food half hour before you eat. For some people, it has to be an hour, but 30 minutes to an hour before you eat. And then if you've eaten, then waiting at least 1 hour before you take the medication to avoid that issue. Some people, like you said, are more sensitive than others, and they may notice even if they space out their meds, they still have some issues with the absorption during the day. So sometimes we'll say maybe try to move most of your protein to dinner time or to the end of the day. You still want to take in enough protein, but just moving it later when you're less active and taking other types of food earlier to avoid that interaction. Certain formulations of levodopa may be better if you're really having that interaction between protein and food, like different ways of administering levodopa, whether it's the nasal route or now we have the patch pump available. Or Ritari might be a little bit better, and the newer Ritari to the Crexont is supposed to be a little better for that type of absorption. So there are ways around it. But yeah, in terms of vitamins and supplements, I feel like there's not that much data out there, and really the absorption issue is more related to the protein because of the same transporter that they use. So I don't think there's that much interaction with vitamins and supplements. I don't know, Tamara, if you've read otherwise.
Not in relation to absorption of the levodopa, probably more just related to maybe I think that there's, sometimes patients with Parkinson's have lower levels of B12 or folate, and so supplementation can be a good idea. But always, keeping in mind to keep track of some of these, vitamins with your primary care as well.
I mean, is it safe to say that you can experiment a little bit with this? Like some people don't notice a big difference, and if you do, then space it out. And if you don't notice a difference, then you're good.
Yeah,
right.
Exactly.
There's no hard rule about that. Yeah.
Yeah,
That's my recommendation.
Change with the what stage of disease you are. Early on, you may not notice much difference at all, but once you're having more ups and downs of the medications, then you might notice it more.
Yeah. Thank you.
I just put the name of that new medication in the chat that Dr. Luther mentioned called Crexont. It's like a Ritari with an extended release and immediate release. I just put that in the chat. There's a question about iron. You mentioned earlier that anemia, women are more likely to have anemia. Is there any data around iron deposition in STN? I'm not sure what that means. Tissue analysis postmortem. So is there any data around iron deposition in STN, women versus men? So this is in the context of iron synthesis and overload between menopausal women and men.
Yeah, it's a good question. I don't know that I know the answer to that.
I don't know if there's any data that's really looked at the differences between men and women specifically, but I think that we do know that in general STN, or we do tend to see, iron deposition and what this like iron maldistribution, right? This, away from the bloodstream and more of an overload in the brain or the substantia nigra specifically. And we do see that sometimes in Parkinson's, because we tend to see more iron deposited in the substantia nigra specifically of patients with Parkinson's. But I don't know about the STN or if there's a difference between men and women.
There's one more question here about swallowing. How can you address swallowing problems? I know there are specialty physical therapists for voice and swallowing. That's very effective. So could you speak a little bit about that?
Yeah, I think if somebody is having any swallowing issues, seeing a speech and swallow therapist can be very helpful. And thankfully in the Bay Area, there are plenty of people, you can find, especially those who are familiar with Parkinson's disease. I think LSVT or Lee Sillerman, voice therapy program, even though it's more speech, but they also will sometimes do the swallow evaluations and swallow therapy. Yeah.
Yeah, I mean, depending on the type of insurance you have or which doctors you see, you can get an ENT exam, which then will refer you to a PT, a specialty Parkinson's PT person that works with people with Parkinson's. So your PCP can refer you to ENT, and then the ENT can send you to a physical therapist that specializes. That's one good route to go.
Yeah, especially maybe in the Kaiser system too, because you probably have all of that in there.
Yeah.
Here's a question around whether there's any data that around age-adjusted scales, the Unified Parkinson's Disease Rating Scale at baseline, so upon presentation. Are there any differences in the scores between men and women?
I mean, I think a lot of the things that Dr. Steep mentioned probably came from that, because that is how we usually analyze the motor symptoms. So, the decreased rigidity and the more dyskinesia and things like that she mentioned were probably pulled from the scales. But in terms of the total, burden of skills, I can't think off the top of my head what the scores are. But there's definitely studies that have compared those scores directly by like PPMI, for example, is a age matched study, and they may have more specific data on the scores for men versus women, that there's a difference by age. But yeah, that would be a good way to look at the baseline motor severity for men versus women.
Great, thank you. And another sort of men-women comparison question. I know there's probably a lot, like you said, there's a lot of lack of a lot of data. But have there been any studies on percentages of women versus men participating in exercise programs that help slow the progression of disease? I mean, we know exercise helps slow the progression of disease, but I guess the specific question is, are there pronounced differences between men and women?
Yeah, I don't remember the percentage off the top of my head, but I did see that that women were less likely, especially postmenopausal women, were less likely to participate in exercise programs compared to men. And part of me wonders if that's due to all of these other issues, like having more responsibilities, or trying to juggle different things, or putting yourself first, things like that. Or is it related to the non-motor issues, the psychological issues of fatigue or depression, and not wanting to exercise, the lack of motivation? But there has been they have shown that women may be less likely to participate in exercise programs.
And it seems like there's also research that shows that that the social exercise are more beneficial for women too. So group classes and things like that. So because it satisfies both the need for connection and interaction as well as exercise. And on that note, I will just say, if you haven't already, check out our website for all of our amazing exercise classes that we have. And furthermore, the research also shows that the peer connection is really a critical piece. And so again, that's one of the reasons why we started this women's support group, is so that women could have a really safe space to sort of interact with each other and share their concerns and needs that are really unique to being a woman. So please join us on Tuesday, December 3rd, if you haven't already planned on that. Donna, do you have another question?
There is one other question. It's not necessarily a gender orientation. It's about pelvic floor issues, and it's just about just urinary incontinence. And I think, again, another great reason to connect your neurologist with your OBGYN, because if you're having pelvic floor issues, you're having urinary or bowel incontinence, then you can find your way to a specialist, a referral for pelvic floor PT, which is also reportedly very effective. And it's not something that we talk about because it's kind of embarrassing or stigmatizing that you're having incontinence issues, but it's really important in terms of your quality of life. And so talk about it, and, talk to your OBGYN and connect your neurologist together, because you can get a referral for a PT, pelvic floor PT specialist. And it's, it, it just has to be talked about. That's all. It's not a fun thing to talk about. It's not a fun kind of physical therapy to receive, but it can be really effective, and it can really change your quality of life. So that's a vote again to connect your healthcare providers so that you're all talking about what you need and how to get there.
There's a question too in the chat about using your primary care physician
Yeah.
to facilitate communication between specialists. Can you either of you speak to that? Is that a sort of useful route to go?
I think it definitely, depending on how active or how close you are to your primary care, and what your primary care practice structure is like. Some people will have more of a concierge type primary care, and they would have a lot more time and a lot more resources available to them to be able to give more of that that like liaison care. If you're in a really busy primary care office, they might not have the bandwidth to be able to kind of like make that connection for all of us. So it just depends on like what you and your relationship with your primary care is really like, and what they can offer. But yes, I think so. I think in some cases it definitely is very useful, especially if they're all in the same system. I've had several patients where I'm able to, message several of their providers at the same time, because we're all in the same system, and so we communicate much easier that way, versus communicating with someone outside of a different system can be sometimes much more difficult in that coordination. And that would be my second option, trying to find all of your care providers within the same system, because it just makes communication so much easier. And really all of the providers can communicate together instead of one with the other, or the other one with the other one, and then, things getting missed.
And I think in some healthcare systems now there have like actual care management teams that can facilitate those sort of,
Yeah.
when you're managing a complex chronic disease, for example, there's services that I know at least
Definitely.
Pfizer has, where that will help you sort of
Yeah.
integrate and facilitate your conversations.
Yeah, there's health portals where all your appointments are in there, all your visit summaries, all your lab tests and results. So it's coordinated and visible to all of your healthcare providers at the same time.
There's a really interesting question in here. It's sort of more of a global question about, are there other cultures where, outside of the US, where they manage the Parkinson's sort of more positively with, with regard to sort of gender issues, or probably just in general. Maybe that means I'm not sure exactly what the question means, but maybe like less stigma or less care integration. Do you guys have any thoughts on how, Parkinson's is treated in other countries?
A great question. I don't know. And I think it may be more even broadly, like how are women's health issues treated in other countries? You hear about countries that are more generous with maternity leaves and giving women the time and care that they need to take care of themselves like that. So I wonder if PD is treated differently in those countries, but I don't know if it's been discussed even in research where people have compared across countries. You know, people may just mention some experiences from their group, but I think that was one of the things in the agenda too, to try to look at this more globally and connect women more globally as well. So maybe somebody is doing better than us at this, and we should learn from them. So
We'll be interviewing Dr. Bass Bloom from
yeah,
Holland in February, and we can ask him the
we
same.
can ask him. Yeah.
And we usually have members go every year to the World Parkinson's Conference or Congress, I think it's called. So maybe that's something that we can be thinking about as people
Yeah.
go off to that next. Wait, it's every 3 years, right? And I think it's in the US next time. So maybe more people will be able to go.
Yeah, and I think last year they had like a women's specific forum at that conference. It's a great conference to attend, and hopefully they continue the women's discussion.
That's great. Thank you. And someone did chime in that Linda Ronstadt is a famous female person. I didn't know that. Thank you.
Didn't know
Good
that.
one.
I'm sure there are others, but all right. Let's see. Is there any other questions? Anybody else in the audience feel like asking a question directly? You could raise your hand and we can call on you.
I do see one interesting one here, Monique, that I'll grab real quick. It's
Great.
someone's saying, since constipation and sleep issues are common effects of menopause, but they're also prodromal symptoms in PD, they might often get ignored. But other symptoms like dry eye might offer earlier diagnosis if alpha-synuclein is identified, et cetera. So it's more of a comment and an observation, but if you have any follow-up or confirmation on that, that would be helpful.
Yeah, I mean, I think they kind of said it right, that it is a prodromal symptoms, sometimes constipation, but it can also be more vague, and you know, people may relate it to other things like menopause or IBS or something.
And do you think that might occasionally lead to gaps in diagnosis because people
For
are
sure. Yeah, I think, yeah,
taking that as menopause instead of?
exactly. They may confuse it as something else. Yeah.
Thank you.
I wanted to wrap up with a question about your research, Dr. Luthra. I think that in the intro we said that you had an NIH-funded study that you were working on. Would you mind sharing a little bit about what that work is?
Sure. Well, it's an exercise study.
Okay.
So it's looking at the effects of exercise on both motor and non-motor symptoms in people with Parkinson's, including cognition and things like mood and fatigue. And it's also looking at how exercise affects things in their blood and brain to try to understand how exercise has benefits. It's the exercise itself is all remote. It's a 26-week program where people will exercise with a virtual trainer, and they'll do a combination of aerobic exercise and strength training. And they'll come to UCSF before the study and at the end of the study for us to look at the differences. And we're trying to enroll, it's a small study for now because it's just at UCSF. So we're enrolling about 36 people here, men and women. But to be eligible, you have to not already be exercising intensely. So we want to try to take some of the non-exercisers or not regular exercisers and get them exercising. But otherwise, you can be, on Parkinson's medications to be eligible for this study. You can even have DBS to be eligible for this study.
Oh, great. Thank you. Is that the Excel or the Spark 3?
Yes, that is the Excel PD. And then Sparks 3 is more for early Parkinson's, so within a couple years of diagnosis. And that's a longer study because Excel PD is just 26 weeks or 6 months. Sparks 3 goes for 18 months of exercise, controlled exercise.
Great, thank you. And then the two Fox Insight studies that you mentioned, those were both questionnaires. Are
Mhm.
those things that anybody can complete? That's not
Yeah,
like there's
I didn't put
eligibility
the
criteria.
exactly. I forgot to put down the website, but if you Google, yeah, Fox Insight, you can join the study, and that's one of the questionnaires in there. But they may have you do some other, or maybe you can just pick those questionnaires to do. I'm not sure. But yeah, it's eligible ongoing for both healthy and people with Parkinson's, and they want to collect as much information they can to try to understand patterns and things like that. So.
Great. And I think the PPMI is also available to people who are care partners. You don't have to have
Mhm.
Parkinson's. Are you still enrolling controls for that as well?
I forget. Yeah, I think they're still enrolling controls too in the new phase. Yeah, they're enrolling women still, and they're also enrolling controls. Yes.
Great. Excellent. All right. Well, if there's not any other new questions popping in, I think we can go ahead and wrap up. Thank you guys very much for joining us today, and especially on a Saturday morning. We really appreciate your time, and we'll be emailing the recording with some of the links of the things that we talked about today. So thank you guys again for joining us, and thank you, Todd and Donna.
Yeah, thank you. It's been great.
Thanks, ladies.
For
Appreciate
having
your
us.
time.
Great.
Thank you.
Thank you. Before we sign off, Monique, I just wanted to remind folks, because somebody asked how to save the chat information. I put those quick little instructions in the chat, but basically there's a series of 3 dots in the very bottom right corner of the chat panel. If you click on that, the first option at the top should be Save Chat. And that will take you to a dialog box that asks you where on your computer you would like to save it to.
Thank you. It looks like Margaret had a question. Why don't we see if she wants to ask her question live real quick before we sign off?
All right, ladies, one more question.
Hi.
Hey, Margaret, are you there? Can you hear us? It's your turn.
You can unmute yourself.
I
There you
just
go.
wanted to add, people said that Linda Ronstadt had Parkinson's, so I quickly Googled it and
It's-
she had PSP.
Mhm.
Okay. I'm gonna Google famous women with Parkinson's after this.
Yeah, that would be good.
Mhm.
All right. Thanks for clarifying.
Thanks, Mark.
We don't want to start any rumors.
That's
All right. Have a great weekend, everybody.
Bye, everybody. Thanks for your time again, ladies. Bye.
Bye.